welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hello, I am Isabel Olivera, a medical writer for EHA. Today we're thrilled to have with us Professor Maria Domenica Cappellini. Professor Cappellini is a professor of medicine at the University of Milan, and she's a leading authority in hematological disorders such as thalassemia, sickle cell disease, and anemia. For her outstanding career dedicated to the understanding and management of these diseases, she received the Jean Bernard Lifetime Achievement Award at the EHA Congress in this year, 2024. And so we want to revisit your career with you in this podcast. Welcome, Professor Cappellini, and thank you very much for being with us today.
Thank you for inviting me.
To start off, I wanted to go really back in time, and can you explain us what inspired you to work on thalassemia and hemoglobinopathies in general?
We have to go back to my residency time, which means the end of 60, early 70, when I was doing my training in internal medicine. And I was trying to find out something interesting to develop and to get involved. And I had to thank my mentor, who at that time, he inspired me because he said, listen, could you be interested in a disease which is not so common now in internal medicine, but it will be in the future because pediatricians are starting to take care properly of these patients. They are the thalassemia patients. I was a bit shocked because thalassemia was not common in our region. I'm living in northern Italy, in Milan. It was more common in south, in the island. So I say, that's quite strange, but let me see. So I started to look more carefully in patients admitted to the internal medicine ward. I started to look more carefully to the anemia in these patients, any kind of anemia. And at one point, I encountered a patients admitted for mild anemia, mild splenomegaly, mild jaundice, and he was admitted because of persistent fever. He was a man of 45 years of age. And what was surprising me was the microcytic anemia. So he had small red cells, but of course his iron was totally normal. So I said, let's see, he was from Sardinia, a region with a high prevalence of thalassemia. So I said, let's see, maybe he's a carrier. But it turned out that he was not a carrier, but he was an affected patient with severe thalassemia, the one we used to call thalassemia major. And that was really surprising because how can a 45-year man be alive being a thalassemia major? So that actually excited me. I asked him to look at all the family, and he has 3 children. And the 3 children, 2 of them were carrier of beta thalassemia, but they had an unexpectedly high level of fetal hemoglobin, which was not common in a carrier, something like around 8-10%. That was another surprising finding in the family. So I say, what is going on here? So I start to contact experts in the field, Professor Bernini in Leiden, who confirmed my observation, and then I contacted Professor Wetherall in Oxford. And starting from this family, I was becoming very much interested in the field of hemoglobinopathies. And just happened that Professor Wetherall invited me to attend a course in Colimbarion, in Crete, where biggest name in the field were meeting to share the starting molecular work on the field. So I went there, and my family was becoming an important core of discussion. And then I went to Oxford for a period, and my interest was focused on that. That was was around the end of 70, when the treatment, the standard of care for thalassemia was just, let's say, defined better in terms of transfusion and iron chelation. And at that time, it was very demanding, because particularly iron chelation was mainly on using desferrioxamine, which needed to be efficacious, to be infused with a pump for more than 7-8 hours per day, all over the life. So I said that's really something very demanding for the patient. Why we are not going to find something new for iron chelation? And since I came back from Oxford, I started to work with Novartis, that at that time was producing the serioxamine, to find other alternative chelator. And it came out that by the end of 90, the Ferazirox was identified among more than 700 compounds. I was leading a clinical trial with this novel oral iron chelator, which is now the standard of care. And I personally believe that this was really an important step for the management of thalassemia, because it really changed the quality of life of patients. Adherence was increased, compliance was increased, and so on. So since then, although I maintain contact with the Oxford group, and we did some other scientific work, but I focus mainly, starting from the 90s, early 2000, I focus a lot on therapeutic approaches in order to offer to these patients better quality of life, trying to identify some alternative to transfusion and so on.
When did you discover the molecular basis of thalassemia? Because that was before, no, in your work in...
Exactly. The definition of thalassemia, clinically speaking, was given to Dr. Cooley in 1925. But it was only after the 60s when a technique to separate the globin chain of hemoglobin was set up, that it was possible to say thalassemia is a type of anemia due to globin chain deficiency. And that was an important step, and that was in 1966. After that, when in the 80s the molecular techniques were made available, thalassemia was characterized at genetic level. And of course, hemoglobin is formed by alpha and beta globin chains, so two major groups of thalassemia were identified according to the molecular defects on the alpha globin or beta globin. Of course, the beta thalassemia are the most important, clinically speaking, because you have only two genes which are controlling the beta globin production, whereas for alpha you have 4 genes. So I'm not going into details, but we focus on beta thalassemia. We characterize the molecular defects of beta thalassemia in Italy, but then we did in many other, we collaborate to do in many other countries. And for that patient I mentioned, for
Yes.
that family, what was the important observation was that he was carrier of two affected beta globin gene, so he was homozygous for the defect, but he had a persistence of fetal hemoglobin. So he continued after birth, during his life, to produce fetal hemoglobin, which compensate the deficiency of beta. So this was an important discovery, which actually opened the view of finding the possibility to treat and to correct beta thalassemia inducing the fetal hemoglobin production.
This is gene therapy now.
And now,
Mhm.
the gene editing based on stimulating the hemoglobin F production is becoming a reality. So I think that that discovery, which was then supported also by study from Swile and the other group, but was really a important step for working on this direction. And my fortune, I have to say, was the possibility of following the natural history of thalassemia, changing a long time from the very beginning when I started, when little was done for treating these children who used to die within at most the second decade of life. So I had the opportunity to follow step by step the improvement because of iron chelation, the improvement on proper transfusion. And now I have patients who are over 60. And now I am so happy that these curative treatment are probably available in the near future.
We are all very excited about the gene therapy, about the fact that now you can, with CRISPR-Cas9, reactivate fetal hemoglobin, but you had also before used hematopoietic stem cell transplantation.
The first, let's say, curative approach was bone marrow transplantation. And the first bone marrow transplantation was performed in 1981. And there was a huge debate at that time because you know that for performing bone marrow transplantation, you need to do myeloablation with, busulfan and very difficult drugs.
Yes.
And at the very beginning, actually, we lost several patients because it was not clear how to conditioning them, they may have graft versus host reaction. So all these things were a bit difficult to face because thalassemia is different than leukemia. I mean, we have to consider many different factors involved in bone marrow transplantation. So at the beginning, there was a lot of debate among those who sustained the idea of bone marrow transplantation and those who were more in favor of improving the standard of care. But then, step by step, and thank you to the Italian group of Professor Lucarelli in Pesaro, all these, let's say, difficulties were overcome, improving the protocol of myeloablation, improving the selection of donors. And now we may say that the European bone marrow transplantation group suggests that BMT remained the first choice in patient aged less than 14 having an HLA identical donor. So if you want to get the best result for bone marrow transplantation, this is the ideal patient. Still, there is a small percentage of risk of graft versus host rejection. What is the advantage of gene therapy or genome editing, where similarly we have to perform the myeloablation, but we are using the patient's stem cell? They are manipulated and then they are reinfused to the patients. So in this way, we are avoiding the risk of rejection, and that is a step forward. Anyway, today, having gene therapy approved in the United States and having genome editing approved in Europe and in the United States, still the agency are suggesting to perform these approaches in patients who don't have an HLA identical donor for bone marrow transplantation.
So the problem with gene therapy that always comes up is the price tag, obviously.
The cost is very high due to the, all the step. You need to do the apheresis, and then you need to send the stem cells to a specific lab who can do the insertion of gene in case of gene addition, gene therapy, or modifying the genome in the case of gene editing by CRISPR-Cas. What is extremely important is to look carefully to the characteristic of patients to be eligible for this kind of treatment. I don't believe that any patients can be treated with gene therapy or genome editing, but to be successful, I personally believe that as it was for bone marrow transplantation, it's extremely important to identify the right patients with low comorbidity, for example. And that's bring me back again to consider the young population instead of the oldest, because in older patients who already have a lot of comorbidity, take into account the cost, we have to balance the decision. And hopefully, as it happens for other treatment, if this kind of approach start to be implemented, probably the cost also will drop, hopefully.
These diseases are very prevalent in the south of Europe, middle-income countries or low-income countries.
Yeah.
And you have been also very involved collaborating with these countries.
Absolutely.
See how to manage these
Yeah.
diseases there.
Yeah.
Gene therapy there, it seems impossible,
Yeah.
I think.
Yeah. I actually collaborated a lot with Middle East country, especially Egypt, Lebanon, Oman, and so on. And they did a lot of progress, I have to say. But then I also contributed to improve the standard of care in India, in China, or in Thailand, where the number of patients are so huge. In India, for example, and often it's difficult for them even to get blood or iron chelation. Now, I should say that a lot has been done for thalassemia, but also for sickle cell disease all over the world. And thanks also to the Thalassemia International Federation, which is a patient association, the knowledge and the management background has been spread over the world. So the level is quite good, but there are countries where still there are a lot of unmet need. But paradoxically, I want to tell you that, for example, in India, where there is a huge bias between rich and poor population, or in other country, some families are ready to move to gene therapy, even if the cost is very high, because they are rich people and they can do that. I feel that we are moving to the equity, is a huge problem to face.
You have also been involved in the development of a TGF-beta inhibitor, luspatercept.
Yes.
Other approaches to treating this that should be cheaper. How is this going?
Yeah, and now there are other molecules such as mitapivat, which is a PK stimulator. I was involved in luspatercept trials. Luspatercept is now registered and officially available in the market in many countries. In this case, the treatment is not a definitive cure, but is improving the burden of blood transfusion and iron chelation. And that was part of my, let's say, vision and my dream to find out how to improve the treatment and quality of life for this patient. In terms of cost, it's definitely cheaper, but you have to consider that this treatment should be done for life. So if you collect all together the cost for a lifelong time, it may be quite high. Gene therapy or genome editing is one shot. If it works, it's done. Of course, the major problem is, okay, it's one shot, but who is supporting such a cost?
So you have witnessed all these advances from identifying the molecular basis, the genetic basis, identifying the first treatments possible so that people could live longer. And even now, gene therapy, all these curative options. What has been your most enjoyable part of this path, or what have you enjoyed about this?
Well, any opportunity make me enthusiastic and very much looking forward. I still believe that the introduction of the oral iron chelator, that's really was an important step forward along the thalassemia journey. Although we had the serioxamine, as I mentioned, by pump subcutaneously, but that was extremely demanding. And at that time, around the 80, we're still losing patients because the compliance dropped. They didn't want to go on with this difficult treatment. And that was painful because instead of losing patients at the age of 10 or 15, but we were losing them at the age of 20 or 25, with an oral treatment, which is a pills now. I mean, that's changed completely the adherence, the compliance. And nowadays, it's quite rare to see patients dying for heart failure due to iron overload in the heart. We see some, of course, because there are patients who are resistant to treatment. But now, I mean, the main cause of death, which was heart failure, is not seen anymore. And that's actually made me really excited. And that is back to 2005, 2006, when the Ferazirox was approved by FDA and GIMA. And now is the chelators used almost all over the world.
With everything that is available, how do you see the management of these patients in the next 10 years advancing? Is it going to advance a lot? But Or
We have now a huge scenario with some pharmacological approaches and some molecular approaches. All of them may have some pros and cons. And what I believe is the main, let's say, the main work is really to be able to follow in real life the result of this clinical trial and to define the profile of patients who may go in one direction or in other direction, and not accepting without thinking which is the best one, because the patients are different one by one. So the near future, and I will not be there to look at that, but for something that I really suggest to the young fellow facing the treatment of thalassemia, to look carefully at the profile of the patient.
so now is to be very careful which patient gets which type of therapy. Yeah, that's where we're at.
Yeah.
Which is a very nice place to be.
Of course.
Compared to where you started. Yeah.
I work on this field for more than 45 years, and for 40 years I had nothing else than transfusion and chelation. Now is a new scenario, an exciting time, and
It must be really, satisfying to have dedicated your life to this disease,
I can be happy.
and to see where this is
Progressing.
It's been a pleasure talking to you.
Thank you.
Thank you very much for coming and participating in this podcast. And thank you to all of our listeners. And stay tuned for our next episodes.